Hi guys, good evening. Can you all see me? Can you all hear me? A quick feedback, please. Can you all see me? Can you all hear me? Quick feedback. Right, so we'll be talking about the topic which we have not done last time. That is going to be your the upper GI portion and the lower GI. So stomach and the intestines are the point of discussion today. तो क्या क्या सवाल आए थे हमारे previous exam में? When you look at the questions, number one was carcinoma stomach. It is a carcinoma stomach. Then it was Meckel's diverticulum. It is the Meckel's diverticulum. Intestinal obstruction. Intestinal obstruction. Intersusception. Intestinal obstruction. Intersusception. Cancer colon. Cancer colon. In this, I can add rectum also. CA rectum. Then hemorrhoids. And fistula in ano. Right. So these were the questions which were asked in our previous exam. If you look at the marks distribution, CA stomach was asked for 10 marks. This is for 5 marks. Intestinal obstruction was for 10 marks. Interception 5. CA colon 10. Hemorrhoids 5. Your fistula and ano is going to be for 5 marks, right? So we'll be covering all these topics in the next couple of hours, and so that you have a sound understanding for all of them. Clear? Wait, I'm just accessing the chat box. Give me 1 second. Right, so let's start with the first topic. That is going to be carcinoma stomach. So they've asked you every single possibility in the carcinoma stomach. They've asked you to write down the classification. They've asked you to the management of CA stomach. They asked you what are the risk factors for CA stomach. So we'll start with the entire components the same. So we'll be talking about the carcinoma stomach. So when we talk about the carcinoma stomach, first of all, we'll talk about the risk factors, right? So what are the risk factors that can result in, what are the risk factors? What are the risk factors that can result in carcinoma stomach? So I can divide the risk factors into 4 categories. One is your nutritional risk factor. Another one is the environmental risk factor. You have the nutritional risk factor, the environmental risk factor. You have medical risk factors. And then you have miscellaneous, or simply categorized as others, right? So when it comes down to the nutritional risk factors, any patient who has a low fat intake or low protein intake. Low fat or low protein intake can induce, or I can say increase the risk for CA stomach. Then if there is a patient consuming salted meat. Now this salted meat can be a salted fish also, which is dried, again increase the risk for CA stomach. Food which is rich in nitrate, so high nitrate rich food or the high nitrate consumption. Increase nitrate consumption. Increased nitrate consumption, obesity, and consumption of complex carbohydrates. Patient consuming complex carbohydrate. So these are the nutritional risk factors that can increase the risk for CA stomach. Now what are the environmental risk factors? When you look at environmental risk factor, any factor or any risk factor that can increase the risk of H. pylori's infestation. For example, when you talk about it, poor food preparation. There is poor food preparation. lack of refrigerator, and poor drinking water. Poor drinking water. So poor food preparation, lack of fridge, and poor drinking water, all these conclude as the environmental risk factors. Now I talk about the medical risk factors. In the medical risk factors, you have prior gastric surgery, H. pylori induced infections that can result in atrophic gastritis or else peptic ulcer disease, any radiation exposure, previous radiation exposure associated with atrophic gastritis, and presence of adenomatous polyps. Now, in the miscellaneous risk factor or the other risk factors, being a male is a risk factor, and especially if you are poor, it is a bigger risk factor. So, low socioeconomic status. It is the low socioeconomic status, right? So these are the risk factors that are going to result in carcinoma stomach, right? Now, when you talk about the carcinoma stomach, well, let's talk about the clinical features. In terms of clinical features, I'm going to tell you about based upon the site. So you can draw the site of the stomach. Let's say this is the esophagus, this is the gastroesophageal junction. Now, to be very honest, I don't want you to confuse more, but according to the CEVERT classification, the CA stomach will start 2 centimeters below the gastroesophageal junction, right? So 1 centimeter above and 2 centimeter below the gastroesophageal junction is still considered to be as esophageal carcinoma. But to avoid any confusion, I will divide the stomach into 3 parts. That is the proximal part of the stomach, the mid body, and the distal part of the stomach. Right. So clinical features will be of typical. We got typical features. If it is present in the proximal third of the stomach, if it is in the proximal 1/3 of the stomach. Now, if it's the proximal 1/3 of the stomach, it's a very logical thing. No? Imagine there's a tumor that is growing across here. Now, if the tumor is growing here, obviously it is obstructing the lumen. Now, if it is obstructing the lumen, the food cannot go inside. Now, if obviously initial presentation of these patients would be of dysphagia. It will be of dysphagia. It will be associated with dyspepsia as well. It will be dyspepsia. And remember, all tumors will have neovascularization, so it will be highly vascular. So whenever the food passes, it will brush with the tumor. Now, as it brushes with the tumor, it is going to bleed, and that bleed will present to you as upper GI bleed. Now, I hope everybody knows the features of an upper GI bleed. Whenever I say upper GI bleed, I associate 3 conditions. Number 1, there is presence of hematemesis, that is blood vomiting. Along with that, it will be associated with, whichever blood goes up will go down also, it will be associated with melena, and obviously blood loss will result in anemia. So it is hematemesis, melena, and anemia is what we call it as the features of upper GI bleed. It will be associated with upper GI bleed. When it comes to dysphagia, it is usually for solids when compared to liquids. So dysphagia will be more for solids when compared to liquids in any form of malignancies associated with the stomach or with the esophagus, right? So the proximal 1/3, this is going to be the presentation that you will see. Now, mid body are usually delayed presentation. So if you say mid body, they have delayed presentation. They are usually associated delayed presentation, or they can present to you as upper GI bleed. They present as upper GI bleed. Then it is the distal 1/3 of the stomach. There is a distal 1/3 of the stomach. Now I say distal one third of the stomach. Imagine if a tumor is developing at the distal one third. What it will cause, it will not allow the content to move out. So it is occupying that lumen. No. Now as it is not allowing the content to move out, there will be gastric outlet obstruction. So here the features would be of gastric outlet obstruction. There will be gastric outlet obstruction. So in this gastric outlet obstruction, what are the features that you will see? The patient will have recurrent episodes. There will be recurrent episodes of non-bilious vomiting. Now why non-bilious? I hope everybody knows it, that the bile duct is going to open onto the terminal part of the second part of the duodenum, and the obstruction is above the level of duodenum. So there's a repeated episodes of non-bilious vomiting. So there is recurrent vomiting is there. It will be associated with abdominal pain. This will be associated with abdominal pain. This will be colicky in nature. There will be colicky in nature. It will also have visible peristalsis. Now, if you want to impress your examiner, you can say the visible peristalsis here is going to be from left to right. So the wave of peristalsis that you see here is going to be left to right because the orientation of stomach is left to right. Colonic peristalsis are going to be right to left. Gastric peristalsis are left to right. So this is how you know you're looking at a visible, you're looking at a gastric or a colonic, I would say peristalsis. Okay? So this is on the basis of proximal one third, mid body, or the distal one third of the stomach. These are the typical features that you're going to see. Now along with that, the common features which will be present in all. The common clinical features. The common clinical features that you will see in all the presentation of CA stomach. There will be presence of abdominal pain. There will be presence of abdominal pain. It will be associated with 3 A's, that is anemia, anorexia, as well as asthenia, that is tiredness, right? Then you have significant weight loss. It is associated with significant weight loss. So abdominal pain, anemia, anorexia, asthenia, which is called as the triple A of any malignancy. And then you have significant weight loss. Then you have the significant, I hope everybody knows, no, significant weight loss. How much is a significant weight loss? When more than or equal to 10% of the body weight, there is decrease. There is more than or equal to 10% of body weight. Body weight reduced in more than or equal to 180 days, that is 6 months, which is an unintended weight loss. This is an unintended weight loss. This will be called a significant weight loss. So all these which I've learned are the typical features of the carcinoma stomach. Then there's something called as the atypical features. So we'll talk about the atypical features of CA stomach. We'll talk about the atypical features of carcinoma stomach. So what are the atypical features of the CA stomach that we have? Number one, you have enlarged lymph nodes. Where else do you see? See, the enlarged lymph nodes will come from top to bottom. So it will be enlarged. There is this enlarged left supraclavicular. There is an enlarged left supraclavicular lymph node. Now this enlarged lymph node name is what we call it as the Virchow lymph node. And this sign is what we call it as the Trozier sign. That is, enlarged left supraclavicular group of lymph node is what we call it as the Trozier sign, right? Now, apart from that, you have enlarged left supraclavicular, right? You have the enlarged left supraclavicular, and then you have enlarged axillary, right? So you have the enlarged left axillary group of lymph nodes. Now, this enlarged left axillary group of lymph nodes is what we call it as the Irish group of lymph nodes. Then you have enlarged periumbilical group of lymph nodes. This is your enlarged periumbilical. This is an enlarged periumbilical group of lymph node. And this enlarged periumbilical group of lymph node is what we call it as the Sister Mary Joseph. This is Sister Mary Joseph group of lymph node. This is your Sister Mary Joseph group of lymph nodes, right? So you have the Trozier sign, you have the Irish group of lymph nodes, and the enlarged Periumbilical group of lymph nodes are called as sister Mary Joseph group of lymph nodes. Now, apart from that, it can also be associated with migratory superficial thrombophlebitis, and this is what we call it as the Trousseau syndrome. See, enlarged lymph node is what we call it as the Trousseau sign, and migratory superficial thrombophlebitis is what you call as the Trousseau syndrome, right? This is what we call as the Trousseau syndrome. Now, apart from that, it can also have the what happens when the tumor, see a stomach tumor which is arising from the mucosa, it pierces the entire wall, goes to the serosa, and then it start falling into the peritoneal cavity. In females specifically, that drop metastasis can go onto the liver, into your ovaries and regerminate, and that is what we call it as the Krukenberg's tumor. It's what we call it as the ovarian metastasis. What is the ovarian secondaries? Then the same drop metastasis can go into your rectovesical pouch, and that is resulting in, all that collection will result in rectal indentation, and that is what we call as Blummer shelf. It's called Blummer shelf, and this is what we call it as rectovesical. We call it as, or they can say pelvic metastasis. These are pelvic secondaries. Skin lesions that you can see, number one is going to be the lesser trilate sign, and another one that you get is going to be tripe palm sign. You have the lesser trilate sign and the tripe palm sign. Now, what is your lesser trilate sign? Your lesser trilate sign is nothing but multiple seborrheic keratosis. Those are multiple seborrheic keratosis. And your tripe palm sign is nothing but hyperkeratotic palm. Only hyperkeratotic palm. Now remember, in lesser trilate sign, this multiple seborrheic keratosis. Now you will have patches, the skin patches. In tripe palm sign, you will have scaly palms. So these are the atypical features of the carcinoma stomach, right? Now, whenever you have a patient who has presented with the CA stomach, I would like to evaluate. Obviously, when you have features of upper GI bleed, any patient with upper GI bleed, you have to evaluate it. So in terms of investigation, what are the investigations that we can do? So looking at the investigations. So the investigations that we can perform here, the first investigation would be your upper GI endoscopy. So in an upper GI endoscopy, there will be presence of growth. Now in this presence of growth, you have to take a biopsy. So we will take a biopsy from the upper GI endoscopy. Now, based upon this biopsy, we have a classification, or I can say based upon the HP, we have a classification which is called as the Lauren classification. So what is this Lauren classification? In the Lauren classification, you can have two types of the CA stomach. Number one is the intestinal type of CA stomach. And number two, there could be a diffuse variety or the diffuse type of CA stomach. Now, the criteria in which you will be looking at is the sex, which is usually going to get involved, the usual age of presentation, the genes which are associated with this, is there any specific risk factors. Then you talk about the mode of spread, for these malignancies. Then you have what is the HP findings that you can have and what is the prognosis. So this is the line on which we are going to ask the questions. Now talk about the intestinal variety. The intestinal variety, it is more common in males when compared to females. Diffuse variety is more common in females when compared to males. The usual age of presentation for intestinal variety is age above 50 years. It is relatively seen in younger age group, that is 30 to 40 years. The genes which are associated here is going to be your APC gene, P53 gene, and P16. Here it is associated with E-cadherin gene mutation. Along with that, along with E-cadherin, there is P53 and there is P16 mutation. Is there any specific risk factor? Here it is associated with intestinal metaplasia. It is intestinal metaplasia, and the diffuse variety is associated with blood group A. It is associated with blood group A. The mode of spread is going to be hematogenous, that is blood, whereas here it is usually associated with direct or lymphatic spread. Direct or the lymphatic spread. HP is usually a gland forming variety. Usually you see a gland forming variety. Here you will see presence of signet ring variety. Here it is relatively a good prognosis, and here it is going to be relatively a poor prognosis. Now this is something that you have to remember from our exam perspective, that is a Lawrence classification. If you do, when you talk about CA stomach and you mention Lawrence classification, then your examiner is bound to get impressed. There is no if and but in that. That means you understand the oncology principles and its management, and that is what your Lawrence classification is trying to tell you. Okay? So this is the difference between the intestinal and the diffuse variety that you will see in CA stomach. What are the other investigations that you can do? Now once you have confirmed it, remember I can also do an endo ultrasound to know the T staging. I can do a PET-CT as well. Now PET-CT is basically to look for staging. The PET-CT is done for staging. Okay. Now, based upon the same upper GI endoscopy, the image classification that you have. So based upon the upper GI morphology, when you do an upper GI endoscopy, and based upon the morphology that you see on the endoscopy, we have two variants of gastric carcinomas that you have, which can be classified. Number one is going to be your Japanese classification. Another one is going to be your Borman's classification. Your Japanese classification and the Borman's classification. Now it is both on the basis of your upper GI endoscopy, right? Now Japanese is classified for early GI malignancies. And Borman's is for advanced GI malignancies. Borman is going to be of advanced GI malignancy. Hi guys, good evening. Okay. So in the Japanese, how does it look like? I'll just quickly run through the basic objective. So imagine if this is the tissue block that we have, right? So I have different varieties. We're just going to name them. I need a couple of them, so I'll just quickly add them here, add them further here. I need 5 of them. So 4, then 5. What I'll do is I'll take this entire thing, copy it, and put it here. Smart, right? So you have the early for your Japanese and the Borman's. So let's look at the growth presentation, right? Now, when you look at the early gastric cancers, the type 1 variety will have a protrusive growth like this. This is a growth which is going to be present here. In type 2 variety, it will be a flattened growth. It is going to be like this. Type 3, it is going to be in the same level. It is going to be in the same level of the tissue. In type 4 variety, you see there is an ulcer being formed, but this is only just depressed. So the small ulcerated form which is here. And the next variety is going to be completely digging in, which is called as an excavated variety. So see, it is going to be like this. This is excavated. So if I put these into perspective, this is what we call as type 1 variety. This is your type 2A variety. This is your type 2B variety. This is your type 2C variety, and this is your type 3 variety. Now type 1 variety is what we call it as the protruded variety. This is your protruded variety. This is flat and elevated. This is 2B is only flat. 2C is only depressed. And type 3 is going to be, it is going to infiltrate into the surrounding wall, so it is called as excavated. So we have the protruded variety, flat and elevated, flat, depressed, and the excavated. This is your early GI malignancy. Let's say if this is an advanced GI malignancy. So in an advanced GI malignancy, number one, you will see presence of a polyploidal growth. Number two, you see there is an ulcerated lesion, but this ulcerated lesion is going to have an elevated margin like this. The third variety is going to be only an ulcerated lesion. There is an ulcerated lesion. 4, it is going to involve a transmural thickening, which is like this. And this is going to be non-classifiable, something like this, right? So this is your type 1 variety, this is your type 2 variety, this is your type 3 variety, this is your type 4 variety, this is your type 5 variety. Type 1 is what we call it as the polyploidal type. It's the polyploidal type. Type 2 is ulcerated lesion. It's an ulcerated lesion with elevated margin. With elevated margin. This is only an ulcerated lesion. Type 3, type 4 variety is going to be, it is going to infiltrate the entire wall, and one of the histopathological name that you have is the Linitis plastica. This is the Linitis plastica, and type 5 is non-classifiable. Type 5 variety is your non-classifiable. Type 5 variety is a non-classifiable. So this is about the Japanese variety, and this is about the Borman's classification. For the Borman's classification. Then comes the TNM classification for CA stomach. In the TNM, T is the size of tumor, N is the lymph node, M stands for metastasis. You have T1A, which is only involving the lamina propria. If the tumor involves only the lamina propria, it is T1A. Then it is T1B, which is only going to be involving the submucosa. Then you have the T2 variety, where it is only involving the muscularis. It is only involving the muscularis propria. Then you have T3 variety, where it is going to involve the subserosal space. Then you have the T4A variety, which is tumor perforate serosa. Tumor perforates serosa. Then you have T4B, where tumor involving adjacent organ. Tumor involving adjacent organ, right? So this is going to be lamina propria. So T1A is involvement of lamina propria, then you have the submucosa, then you have the muscularis propria, then you have the serosa, then it's beyond serosa, and ultimately it is going to go and invade to the surrounding organs. Okay, that is your T status. When it comes down to lymph nodes, the lymph nodes N0, there is no evidence of any lymph nodes. No evidence of enlarged lymph node. Then you have N1, where you have 1 to 2 regional lymph nodes are positive. N2 variety, where you have 3 to 6 regional lymph nodes are found to be positive. N3A, you have 7 to 15 regional lymph nodes are positive. And N3B is lymph nodes more than or equal to 16 are positive. Right. So this is, I recently had a laparoscopic cholecystectomy and ERCP. Okay, Manas. Fine. So these are the end staging. M stands for M0, there is no evidence of metastasis. There is no evidence of metastasis. M1, there is evidence of distant metastasis. There is an evidence of distant metastasis. Clear? Sure. So, once you have the staging, let's talk about the management. We have the management. Management of carcinoma stomach. So in the carcinoma stomach, we'll see whether it is operable or whether it is inoperable. Whether it is an operable or whether it is an inoperable malignancy. Inoperable is like, distant metastasis and everything is present. There's no point operating. In this patient, I would basically allow the patient to feed. So the whole problem is about feeding. So here in an inoperable condition, if it is associated with obstruction, that is gastric aortic obstruction, you can do a feeding jejunostomy, or you can also try something called as SEMS. SEMS is your self-expanding. It is the self-expanding metallic stent. Right? Inoperable with gastric outlet obstruction. These are the two options that you have. If it is inoperable, it all depends upon the site where it is going to be present. So we will see whether it is present in the proximal part of the stomach, whether it is present in the mid-body part, or whether it is in the distal part of the stomach, right? Now, it all depends upon that how we are going to cater, if it is going to present at different sites. Okay? Now, if it is present in the proximal, if it is in the proximal, if it is in the mid-body, if it is in the mid-body, or whether it is going to be in a distal part of the stomach. For proximal stomach, it is going to be a total gastrectomy. A total gastrectomy with D2 lymph node clearance. Mid-body will again go ahead with almost total gastrectomy. We'll do a total gastrectomy with D2 lymph node clearance. For distal, it is going to be a partial gastrectomy. We'll do a partial gastrectomy with D2 lymph node clearance, right? So whenever you're doing a total gastrectomy, you have to create a reconstruction, right? So in a total gastrectomy, so we'll see the status after total and after partial gastrectomy. So you have the total gastrectomy and then you have the status after partial gastrectomy. So you have the total gastrectomy and the partial gastrectomy. So this is the esophagus. This happens to be the stomach. This happens to be the duodenum, and the jejunum would continue across here. In a total gastrectomy, I am removing the stomach completely. So this much amount of the intestine is lost. So this much amount of the stomach is being removed. Now when you remove this much amount of stomach, what are you left out with? You're left out with the esophagus and the duodenum and the rest of the jejunum. So what I'll do is, I will close the duodenal stump. I will close the duodenal stump is going to be closed completely, right? Now once the duodenal stump is closed, what I'll do is I will isolate the jejunum. So I'm going to take the jejunum out. So what I'll do is I will isolate the jejunum. That means I'll cut the jejunum here. So once I cut the jejunum here, now I have the two loops of the jejunum. The one that comes first is what we call it as the proximal end of the jejunum, and this is what the distal end of the jejunum is. I will mobilize the distal end of the jejunum. So the distal end of the jejunum is going to travel, it will reach all the way here, and I will make an anastomosis with that of the esophagus, and this is the jejunum which is going to be taken across here. And you see, as the jejunum continues to travel, this end of the jejunum will be anastomosed with the rest of the jejunum, and this continues to go. right? This surgery where you have anastomosed the esophagus. So this is the esophagus, this is the jejunum. This is what we call it as the Roux-en-Y esophago. Roux-en-Y esophago jejunostomy. It is Roux-en-Y esophago jejunostomy. It's a Roux-en-Y esophago jejunostomy. Clear? So now you know what is the Roux-en-Y surgery is. So in the Roux-en-Y, you divided the jejunum into proximal and distal end. The proximal end is still left here. This is the proximal end. This is the distal end, which is taken up all the way to the esophagus, and then here at the level of the esophagus, they have made an anastomosis. This is what we call it as the esophagojejunostomy. Now, why you have left here is the duodenum part, because this common bile duct opens onto the second part of the duodenum. So you want the bile to flow across here so that the bile can go into the food. And whenever the patient is going to eat, whatever he eats, the food is going to come from here, enters into this part of the jejunum, and together it can travel. So you have created two limbs. One is called as the biliary limb. Another one is what we call it as the food limb. And together they move together, and then it just goes in, right? So this is what you do in a total gastrectomy. You know, total gastrectomy. Clear? Clear, guys? Okay. So Roux-en-Y is important when you do a total gastrectomy. Now, what changes in a partial gastrectomy is, one second, guys. Okay. So in a partial gastrectomy, when you look at this, same thing, nothing changes. In a partial gastrectomy, this is the part of the stomach. And the same thing, you have the duodenum, you have the jejunum, everything is going across here, nothing has been changed, right? Let's say there's a tumor which is present here. That is in the distal 1/3 of the stomach. Now the basic rule here is, when you take, this is the upper margin of the tumor, this is the lower margin of the tumor, there's something called as proximal and distal margin. Remember, in carcinoma stomach, the proximal margin of the stomach has to be 5 centimeters and the distal margin of the stomach has to be 5 centimeters. So ट्यूमर के ऊपर 5 सेंटीमीटर, ट्यूमर के नीचे 5 सेंटीमीटर निकालना जरूरी है, ठीक है, ये बेसिक है. So उसकी वजह से क्या होगा, what is going to happen, I'm going to remove this much amount of the stomach is going to be removed. So this much amount of the stomach is going to be lost. So what I'm left out with, there's a part of the stomach which is left behind, which is here. Okay. Now again same thing, I'm going to close the duodenal stump. So duodenum को हमने बंद कर दिया. I have divided the jejunum right across here. तो jejunum को divide कर दिया. jejunum को divide करते ही हमारे दो लिम्ब बनते हैं, जैसे हमने पहले बताया था. ये आपका proximal limb है, ये आपका distal limb है. Proximal limb में आप देख रहे हो कि आपका bile duct is opening and this is where the bile is going to come. तो मैं क्या करूँगा, distal limb को migrate करा दूँगा. So when I take the distal limb, I'm going to pull the distal limb. Distal limb को यहाँ पे आपने announce करा दिया. So this is where the distal limb, again it is closed. यहाँ पे stomach की opening है, आपने jejunum को side में open किया, and then you made an anastomosis of the stomach with that of the jejunum. So gastrojejunostomy में end to side anastomosis होगा, end of the stomach to the side of the jejunum, end to side anastomosis. बाकी आपका जो jejunum है उसको लेके नीचे चले गए, तो jejunum जा रहा है जा रहा है जा रहा है. This is how the jejunum is traveling. और ये जो आपका proximal end of the jejunum है, इसको आप इसके साथ मिला दोगे, and then you will allow it to continue across here. So same story, ये आपकी proximal end of the jejunum है, ये आपकी distal end of the jejunum है. You will see the bile duct which has been opened out of the second part of the duodenum will allow the bile to flow. So ये bile flow हो गया. Patient जब खाना खाएगा, whenever the patient is going to eat the food, that food is going to enter via the stomach into the jejunum and the food will continue to travel, and from here it will become a common channel. From here you will see both food and bile is going to mix together and go together, right? Now this surgery is what we call it as Roux-en-Y gastrojejunostomy. This is what we call it as the Roux-en-Y gastrojejunostomy. If you want to impress your examiner, you can say this is an end to side anastomosis. This is an end to side anastomosis. Okay? So this is how you're going to talk about the management of your carcinoma stomach. You can also add the last nail in the coffin, that is a post-operative chemotherapy. So in a post-operative chemotherapy, the regime is going to be ECF, that's the mnemonic. E stands for epirubicin. C stands for cisplatin. And F stands for 5-fluorouracil. So epirubicin, cisplatin, 5-fluorouracil, these are the components for your CA stomach. Clear? So an elaborate discussion पूरे carcinoma stomach में from its risk factor to its clinical presentation, typical, atypical, इतना लिखोगे तो लोग पागल हो जाएंगे. ठीक है? Clear? Clear guys? So we finished the first question, which was of 10 marks. That is going to be carcinoma stomach, right? So done with CA stomach. So next we go with Meckel's diverticulum. So Meckel's diverticulum is actually a short note. So we'll quickly talk about the Meckel's diverticulum. So talk about Meckel's diverticulum. Remember, Meckel's diverticulum, it's a congenital diverticulum. It is a congenital diverticulum formed due to the remnant of vitalo-intestinal duct. Due to a remnant of vitalo-intestinal duct. So it's a congenital diverticulum formed due to a remnant of vitalo-intestinal duct, and that is what we call it as the Meckel's diverticulum. Now, when you look at the whole concept, this is where the yolk sac is going to be present. This is your vitalo-intestinal duct, and through the vitalo-intestinal duct, you see the bowel is going to arise. So this is how this is going to arise. Normally, we expect, if you take this as the yolk sac, this is the vitalo-intestinal duct. This is the vitalo-intestinal duct, and this happens to be the bowel loop. Normally, this yolk sac and vitalo-intestinal duct should disappear. In few patients, this persists. So the persistence of this vitalo-intestinal duct on the bowel segment. Is what we call it as the Meckel's diverticulum. So this is what we call it as the Meckel's diverticulum. This is a Meckel's diverticulum, right? So talk about the important points about the Meckel's diverticulum. Remember, this is an example of a true diverticulum. This is an example of a true diverticulum. This arises from anti-mesenteric border. This arises from anti-mesenteric border. And remember, they follow something called as the rule of 2. So what is the rule of 2 in the Meckel's diverticulum? So in the rule of 2 of the Meckel's diverticulum, number 1, it is present in 2% of the population. It is present in 2% of the population. That is why this is the most common congenital. This is the most common congenital abnormality of the bowel. This is the most common congenital abnormality of the bowel. How long it persists? It will persist until it is removed. Correct, beta. So it's formed is formed. It's not necessary that every patient of Meckel's diverticulum will become symptomatic. No. In fact, less than 10% of the patients who have Meckel's diverticulum become symptomatic. The rest of them remains asymptomatic for life. So it's 2% population. it is going to be 2 inches in size. This is going to be 2 inches in size. This is going to be 2 feet approximately, that is 60 centimeter proximal to ileocecal junction. It is 2 feet proximal to IC junction, and it has got 2 different mucosa. So it can have ectopic gastric mucosa. It can have ectopic gastric mucosa and ectopic pancreatic tissue. So then ectopic gastric mucosa as well as ectopic pancreatic tissue. So this is the rule of 2 that is present in Meckel's diverticulum. So we talk about the clinical features. Clinical features associated with Meckel's diverticulum. Now remember, most of the patients are asymptomatic. Most of the patients are asymptomatic. They are asymptomatic for life. Only 10% of the patients are symptomatic. Only 10% of the patients are symptomatic, and these 10% of the patients are symptomatic. These are due to complications. These are due to complications associated with Meckel's diverticulum. Aviral, there is no risk factor per se. There is no proven risk factor. It's a congenital abnormality that is found. Okay. So it's mostly asymptomatic for life, but then 10% of the patients may present to you with symptoms. Now, when I say 10% of the patients may present to you with symptoms, what are the symptoms that you're looking at? Now, when we talk about the Meckel's diverticulum, many a times now we just jump into conclusion saying the Meckel's diverticulum will be present as it is. No, it is not. You need to understand that it is going to have a feature which is going to be associated with bleed. It is going to have, see, you have ectopic. I'm not okay. Let's not try to overcook this. I'll say simply the complication that can present to us presentation. We'll talk about the complications of the Meckel's diverticulum, which will present to you as clinical symptoms or clinical presentation. As I told you, only 10% of them are going to be symptomatic, and those are due to complications. I can divide the complications in 3 factors. One is bleeding, another one is obstruction, and one more is going to be diverticulitis. Right? So one, it will present to us bleeding, another one will present to us obstruction, and one more it is going to present to us diverticulitis. Okay? Now when I say bleeding, why would a Meckel's diverticulum bleed? And this is quite interesting for us to know as well. Now the bleeding in the Meckel's diverticulum, it is secondary to the peptic ulcer disease in an ectopic gastric mucosa. So this is due to peptic ulcer disease in the ectopic gastric mucosa. Ectopic gastric mucosa. Now when it bleeds extensively, it is going to present to you with melena. It can present to you with fresh blood, that is hematochezia. And obviously extensive blood loss will also result in anemia. So lower GI bleeds, right? Melena, hematochezia as well as anemia are going to present. So this is about the bleeding. It can also present to you as obstruction. So obstruction, how does Meckel's diverticulum cause obstruction? Remember, Meckel's diverticulum is the most common, it is the most common lead point. It is the most common lead point in children for intersusception. For an intersusception. So here the obstruction is due to intersusception. What is intersusception? I'll talk in a bit. Okay? So in intersusception, you see one loop of the ball going into another. Now when it comes down to diverticulitis, now diverticulitis is inflammation. Any itis is inflammation. No, Any inflammation is going to have Ruber-Kaller-Dollar tumor. Any inflammation is going to be Ruber-Kaller-Dollar tumor. Same thing is going to happen. Now that terminal ileum part is present in the right iliac fossa, and the inflammation in the right iliac fossa will present to you patient with pain in right iliac fossa. There is right iliac fossa tenderness. Now because any bowel inflammation will be associated with nausea as well as vomiting, that is going to be present. So there is pain, there is tenderness, there is nausea, vomiting. It will be associated with fever as well. Now imagine a patient is having pain in the right iliac fossa, tenderness in the right iliac fossa, nausea, vomiting as associated with that. There's a fever. All that usually points with the most common differential diagnosis, that is going to be your acute appendicitis, right? So what is the most likely embryological explanation with the percent of gastric mucosa with the Meckel's diverticulum, and how does it relate to the risk of developing of GI bleed? See, Aviril, when you talk about the ectopic gastric mucosa, it's the migration of the neurocrest cells during the embryonic development that happens, right? The exact pathophysiology is not very well unfolded, but it has been found that Meckel's diverticulum harbors. It's all when you talk about the derivatives. No, you have the foregut, midgut, and hindgut derivatives. The foregut develops all the way to the second part of the duodenum. The midgut develops from there onwards all the way to that of the transverse to the colon, and the rest of the hindgut is there. Normally, you talk about pancreas, you talk about gastric mucosa, they are foregut derivatives. So when that derivative component comes into the midgut and it remains or sustains with the vital intestinal duct, that is going to present to you as ectopic gastric mucosa or ectopic pancreatic tissue. Now, why does it happen? I really don't know. Now, why will a patient develop a risk of bleeding? Because when there's a gastric mucosa, now you know H. pylori, we'll talk about it. H. pylori has a very high affinity towards gastric type of mucosa. It can only grow in gastric type of mucosa, nowhere else. Now imagine a patient is infested with your H. pylori, the patient will have peptic ulcer disease in the stomach. The same H. pylori nowhere else in the intestine can grow, but can grow in the Meckel's diverticulum because of the presence of your ectopic gastric mucosa. There it causes peptic ulcer disease, and peptic ulcer disease, erosions will be there, erosion cause bleed. So hence that bleeding is secondary to the peptic ulcer disease in gastric mucosa. Okay? So when the patient develops diverticulitis, the diverticulitis, it is the most common differential. This is the most common differential diagnosis. This is the most common differential diagnosis for acute appendicitis. It is the most common. This is the most common differential diagnosis for acute appendicitis. Okay? So these are the complications. So how does the patient present to you? Patient can present to you with lower GI bleed, that is melena, hematochezia, anemia. It can present to you as intestinal obstruction. It can also present to you as features suggestive of acute appendicitis. Okay? Now, when you talk about Meckel's diverticulum, what are the investigations that you can do? The investigations that you can do, number one is the ultrasound of the abdomen. We can do a CECT of the abdomen. But more importantly, it is the technetium 99 per technete scan. Which is most effective. Now, now technetium 99, it has got very high affinity. It has got very high affinity for gastric type of mucosa. It has got very high affinity. It has got very high affinity for the gastric type of mucosa. Hence, you'll be able to see Meckel's diverticulum. So, whenever you have a patient with Meckel's diverticulum, management, remember, if it is incidentally found, or if the patient is presented with complications. If the patient is presented with complications in Meckel's diverticulum, then it has to be resection and anastomosis. That is diverticulectomy. We'll do a diverticulectomy with primary anastomosis. So we'll excise an anastomose. Now talk about the incidentally found. When you have the incidentally found Meckel's diverticulum, what are the indications for surgery? Now the current indication for surgery, number one, if the age less than 50 years. Number two, if it is a male sex. If the length of the diverticulum, is more than 2 centimeters. If there is presence of ectopic tissue, that means when you did a technetium 99, there is a positive uptake. And if there is any palpable abnormality, the surgery remains the same. That is a diverticulectomy with primary anastomosis, right? So this is how you are going to address your Meckel's diverticulum. Okay. So we have finished your second topic also, that is your Meckel's diverticulum. Now we'll go with intestinal obstruction and the interception in the same consensus so that we understand it better. So next question that you have is about intestinal obstruction. Right, so when you talk about the intestinal obstruction, let's classify the intestinal obstruction per se. So when you talk about the intestinal obstruction, the intestinal obstruction can be divided into two categories. It can be divided into two categories. One, it is a dynamic intestinal obstruction. One, we have a dynamic intestinal obstruction. Another one is a dynamic intestinal obstruction. It's a dynamic intestinal obstruction. Another one is going to be a dynamic intestinal obstruction. So what is the basic difference between a dynamic and an aerodynamic intestinal obstruction is, you take this as a representation of the bowel. This is the bowel loop that we have. Inside this is the bowel wall. This is the bowel wall that you have, right? So these are the loops of the bowel that you have. Now, what is a dynamic and an aerodynamic intestinal obstruction is, let's imagine that this is the proximal end of the bowel, this is the distal end of the bowel. We all know the content is going to move in this particular direction. In a dynamic bowel obstruction, due to some reasons, there is an obstructive lesion which is present inside the, somewhere across here in the lumen itself, there is an obstructive component. Now, because of this, what is going to happen? The content that is supposed to go, anything that is moving inside the intestine cannot move, and will start pooling. And this back pooling of the content inside the intestine is what we call as dynamic obstruction, because there is some visible mechanical obstruction which is not allowing the content to move forward. On the other hand, in aerodynamic intestinal obstruction, the lumen is absolutely fine, but you will see that there is loss of peristalsis. The bowel wall does not have any peristalsis. Now, because the bowel wall does not have any peristalsis, the content is going to stay in its place. It cannot move any further. So the movement does not occur because there is no peristalsis. Hence, what is an obstruction? Where a content is not able to move from proximal to distal, it is getting stuck. Right? That is what the obstruction is. Either there has to be a dynamic or there has to be an aerodynamic cause. Dynamic is going to be a visible mechanical obstruction. Aerodynamic is simply loss of peristalsis. This is what you have to understand. Is that clear? Okay. Now coming to the dynamic intestinal obstruction, the dynamic intestinal obstruction depends where exactly the obstruction is going to occur. Is it going to be intraluminal? Is it intraluminal? Is it going to be intramural? Or is it going to be extraluminal? is it going to be extraluminal, right? Now what do you mean by an intraluminal? So if you take this is the bowel wall, so the inner wall that is there, this is your intramural, and this is your extraluminal. Intraluminal, you see the obstruction is here. Intramural, it originates from the wall and then causes the obstruction. Extraluminal, you see something is exerting pressure from outside, and because of this, now you can see the lumen is getting obliterated, right? So there are three varieties. There are extraluminal, extramural, and extraluminal. Okay? Now what are the causes that will result in an intraluminal obstruction? Number one is your fecal impaction. Number one is a fecal impaction, foreign body. Fecal impaction, foreign body, all the bezoars, that is trichobezoar and phytobezoar. Then gallstones. So fecal impaction, foreign body, trichobezoar, phytobezoar, and gallstones, all these are going to result in dynamic bowel obstruction. That is a intraluminal. What is intramural? One that is arising from the wall, all the stricture, all the malignancies, all the stricture, all the malignancies, intersusception, and volvulus. All these are intramural. What are extraluminal? It could be bands or adhesions. Bands or adhesions, or it could be hernia. It could be hernia, right? So these are the causes for extraluminal bowel obstructions. Okay? Now let it be any extraluminal, intraluminal, intramural, any form. The clinical presentation is going to be similar. So we'll divide the clinical features into two categories. One is with the dynamic bowel obstruction, clinical features of the dynamic obstruction in comparison to that of a dynamic obstruction. So our clinical features, where you have one is dynamic obstruction, another one is your adynamic bowel obstruction. One is going to be dynamic, another one is going to be adynamic bowel obstruction. So when we say dynamic bowel obstruction, number one, there will be colicky abdominal pain. There will be colicky abdominal pain. It will be associated with nausea and vomiting. It will be associated with nausea and vomiting with non-passage. There will be non-passage. There will be non-passage of stools and flatus. There will be non-passage of stools and flatus. There will be increased bowel sounds. That is intensity of the bowel sounds. There will be earlier intensity, but after there will be bowel fatigue, it will stop. But usually in the earlier phase, there will be an increased bowel sounds, like I say, intensity increases. So colicky abdominal pain, nausea, vomiting, non-passage stools and flatus, increased bowel sounds or increased intensity of the bowel sounds are noticed, right? So all these are going to be present in the dynamic bowel obstruction. See, the concept of adynamic bowel obstruction is there are no peristalsis. So the pain in dynamic bowel obstruction is because of intense peristalsis to overcome the obstruction. Here peristalsis are not there. So here patient will have abdominal discomfort. Here the patient is going to have an abdominal discomfort. Now as the content cannot move forward, it is now going to move backward, resulting in nausea as well as vomiting. Again, no peristalsis means no passage. There is non-passage of stools and flatus. So non-passage of stools and flatus. And how do you know it's an aerodynamic bowel obstruction? The bowel sounds will be absent. The bowel sound will be absent. One thing that you remember is in a large intestinal obstruction, there will be massive abdominal distension. In the large bowel obstruction, there will be a massive abdominal distension. There will be a massive abdominal distension because large bowel obstructions are closed loop obstructions. They're the closed loop obstructions. Now, that context, we'll talk about intersusception. So, talk about intersusception. So, talk about intersusception. It is described as intersusception is it's a form of dynamic bowel obstruction. It's a form of dynamic bowel obstruction due to the proximal end of the bowel. To the proximal end of the bowel telescopes into the distal end of the bowel. Into the distal end of the bowel. When the proximal end of the bowel telescopes into a distal end of the bowel, this is what we call it as intersusception. Now, just for the sake of understanding, in a graphical representation, if I put this is how a bowel would look like. Let's say this is the representation of the bowel that you have. Now, due to some reason, if I just simply divide this end of the bowel, we'll say this is the proximal end, this is the distal end, and I'm saying the proximal end of the bowel is going to telescope into the distal end. Once it telescopes into the distal end, what is the end result that you have? In the end result, you see that this end of the bowel is going to go inside and it is going to get accommodative. This is what we call it as intersusception. When the proximal end of the bowel telescopes into the distal end. So this is the proximal end of the bowel. This happens to be distal end. The distal end is accommodating the proximal end of the bowel, and this is what we call it as intersusception. Now, the part of the bowel that is gone inside, this is what we call it as intersusceptum. The part of the bowel that has gone in is what we call it as intersusceptum. And the part of the bowel that is accommodating this is called as the intersuscipiens. So this end of the bowel, which is taking this entire segment in, this is what we call it as the intersusceptum. This entire end is what we call it as the one that is going in. The proximal end will be called as intersusceptum. So this is the intersusceptum, and one that takes in, this is called as the intersuscipiens. So the intersusceptum and the intersuscipiens, right? So what is going to happen is the vascularity of the bowel part which has gone inside, it is going to get compressed, hence it is going to undergo tissue necrosis. You don't want that to happen. Now, not everybody can develop an intersusception. So what are the risk factors? So the risk factor for development of intersusception goes by a concept which is called as a lead point. Now, lead point is defined as it's the point from where intersusception begins. is the point from where the intersusception begins. It is the point from where the intersusception begins, and that's what we call it as the lead point. Okay. Now, what are the examples of the lead point? Remember, in an age less than 1 year, it is usually hypertrophized Peyer's patches. It is your hypertrophized Peyer's patches. It is your hypertrophized Peyer's patches post rotavirus infection. It is the hypertrophized Peyer's patches post rotavirus infection is what is the most important lead point. Okay? So that is age less than 1 year. In children, the most important or the most common lead point is going to be Meckel's diverticulum. Okay, Meckel's diverticulum. In adult, it can be secondary to polyps. Tumor in children. Tumor in children, which will cause interception, causing intersusception, is the small intestinal lymphomas. So look at it, age less than 1, hypertrophized Peyer's patches, children Meckel's diverticulum, adult it is polyp, and tumors in children causing intersusception is going to be a small intestinal lymphoma. All these act as lead point. Okay. Now, how does the patient present to you? Now, in the clinical presentation, remember, in children, it is usually ileocolic intersusception. In adults, it is going to be colocolic intersusception. In children, it is ileocolic, and in adults, it is your colocolic intersusception. As simple as that. Now, when we look at the whole scenario, let's talk about the clinical presentation that you will see. In the clinical features, any intersusception is going to present to you as dynamic bowel obstruction. They will present to you as dynamic bowel obstruction. So in the dynamic bowel obstruction, patient is going to have, number 1, colicky abdominal pain. They have the colicky abdominal pain. It is associated with nausea, vomiting. It is associated with nausea as well as vomiting. There is non-passage. There is non-passage of stools and flatus. There is non-passage of stools and flatus. So the colicky abdominal pain, nausea, vomiting, non-passage of stools and flatus. And here the bowel sounds are usually present with increased intensity. That's the first presentation that you have for dynamic bowel obstruction. Now, if I change this to age less than 1 year, so in age less than 1 year, what will be the presentation? Here the baby is going to have an extensive cry. There's an extensive cry. When you palpate, there will be an empty right iliac fossa. There's an empty right iliac fossa. It results in sausage-shaped abdomen. And sometimes there's a spontaneous resolution of intersusception in children specifically, and there they'll be present with red currant jelly stools. There will be presence of red currant jelly stools. So extensive cry, there's an empty right iliac fossa, sausage-shaped abdomen, and the red currant jelly stool. All these are going to be seen. Now, once you have for any intestinal obstruction, the protocol for investigation is quite simple. Any intestinal obstruction, the first step, it is going to be an erect X-ray abdomen. Especially in children, you have to go with USG abdomen and conclude by doing a CET abdomen. So do an erect external abdomen, then you do an ultrasound abdomen, and then you have CET abdomen. Now specifically when you do a contrast imaging, no, there is a specific sign which is called as the claw sign in interception. In the ultrasound, you will see this presence of target, or also called as the donut sign. They called as the target or the donut sign, right? So this is on the investigation. Management is going to take the patient for exploratory laparotomy and relieve the interception. Exploratory laparotomy, resolve interception, resolve the interception by milking from distal to proximal end. So once it is, if there is a non-viable bowel, so once you have done the milking, if there is presence of a non-viable bowel, then go ahead with resection and anastomosis. Then go ahead with resection and anastomosis. Then go ahead with resection and anastomosis, right? So this is all that you should do. This is all that we should do with respect to intersusception. With respect to intersusception. Okay, so we have finished 2 other topics as well. What are 2 topics that we had? Intestinal obstruction as well as interception. So there were 3 small topics, 1 big and 2 small. That is your CA colon, and then your hemorrhoids and fistula. I know. So start with the cancer colon. Right. Let's talk about the cancer colorectal. Cancer colon as well as rectum, we'll talk about both here. Now, when you talk about the cancer colorectum, by incidence, you should know where do you have maximum, right? Now, if you take this as the representation of the ascending colon, let's say this happens to be the cecum, this is the appendix, this is the terminal ileum. This is the hepatic flexure. This is the transverse colon, this is the splenic flexure. See, anatomically my drawings will be very precise. You will see the splenic flexure is at a higher level when compared to hepatic flexure. This is the descending colon. This happens to be the sigmoid colon. This happens to be the sigmoid colon. As you will see, sigmoid colon will be the narrowest part. This is going to be rectum and the anal canal, right? This is the whole objective that you have. Now, when you look at the entire incidence, I can just quickly talk about the malignancies at the cecum. The cecum consists of 12% of the total cancer colons. Ascending colon, consists of 5% of the total one. Hepatic flexure is 2%. Hepatic flexure is 2%. Transverse colon Transverse colon is approximately 5.5%. Splenic flexure is 3%. Descending colon is going to be 4%. Sigmoid colon will be 21%. Rectum is going to be 38%. Right. So you look at the whole arrangement, no, you will notice the maximum incidence of the entire colorectal cancer around 38 plus 21%. No, sigmoid colon is 21%. Right, so almost 59% of the entire 60% of your entire colorectal cancer is there in the rectosigmoid region. It is just there in the rectosigmoid region. So this is where you will usually see. So majority of the times you see a colorectal cancer, they will be presented with left-sided colonic features, right? Now what are the risk factors that you're looking at? The risk factors for colorectal cancers. Number one, it is dietary risk factor, that is increased animal fat and low fiber diet. This is a low fiber diet. Increased animal fat and low fiber diet. There are genetic components. In genetic components, we have familial adenomatous polyposis. It is a familial adenomatous polyposis, which is called as FAP. Then you have Gardner syndrome. You have the Gardner syndrome, Turcot syndrome. Then you have the Lynch syndrome. That is your Lynch 1 and Lynch 2. That's your Lynch 1 as well as your Lynch 2. These are genetic risk factors. Then presence of adenomatous polyps. Presence of the adenomatous polyps. Then you have inflammatory bowel disease, where ulcerative colitis and Crohn's disease cause equal incidence. History of pelvic radiation. History of pelvic radiation, right? So these are the important risk factors. Now talk about the pathophysiology of the colorectal cancers. So when you talk about the pathophysiology of the colorectal cancers, see, the whole journey starts with a normal colonic epithelium. So initially you have a normal colonic epithelium. In this colonic epithelium there will be presence of dysplasia. This dysplasia will now convert into an adenoma. There are different phases of adenoma that is going to occur, and from eventually it is now going to convert into carcinoma. So you'll see this is initially there will be some amount of dysplasia that will present. So this is your dysplasia. Now from the dysplasia it is now going to form into an adenoma. So there's an adenoma which is present. This is a late adenoma. From there it is now going to become into carcinoma. This is the journey that you need to understand. From a normal colonic epithelium to dysplasia. From a dysplasia to early adenoma. From an early adenoma to that of the late adenoma. And from the late adenoma to that of carcinoma, right? So normal, dysplasia, early adenoma, late adenoma, and eventually becoming into carcinoma. Now what results, or I can say what leads the whole journey? From a normal colonic epithelium to a dysplasia, it is because of APC gene mutation. From dysplasia to that of adenoma, that is going to the whole journey where you can say the dysplastic lesion from early adenoma, early to intermediate, and then to the late adenoma. the two genes which are going to be responsible for this whole transformation. One is your KRAS mutation, another one is your DCC. From the late adenoma to that of carcinoma, it is because of P53 gene mutation. So APC gene mutation takes from normal to dysplasia, from dysplasia to early adenoma, and the late adenomas are because of KRAS and DCC, and from there late adenoma to carcinoma is because of P53 gene mutation. It is because of P53 gene mutation. Clear? Chalo. So talk about the clinical features of colonic or colorectal cancers. So clinical features of the colorectal cancer. So we have the colorectal cancer can divide them into two varieties. One is your right-sided colonic cancers. Another one is the left-sided colon cancers. One is a right-sided colon cancer. One more is a left-sided colon cancer. Now, morphologically, when you talk about just based on the morphology, right-sided colonic cancers will be of two varieties. Number one is your ulcerated lesion. Another one is your cauliflower lesion. The ulcerated lesion and the cauliflower lesion. For the left-sided colonic cancers, it is the tubular lesion and the stenosing lesion. It is the tubular lesion and the stenosing lesion. So morphologically you have two varieties. Ulcerated lesions, cauliflower on the right side, tubular and stenosing on the left side. Now in terms of clinical presentation, remember the right side colon cancers are going to present to you as lower GI bleeds. They'll present to you as lower GI bleed, and this lower GI bleed will be associated with melena. It is usually associated with melena, hematochezia. It is melena, hematochezia, as well as anemia. With that, it will also be associated with significant weight loss. Whereas the left-sided colonic cancers, they will usually present with bowel obstructive features. So they will start with constipation. Then there will be tenesmus, that is urge to defecate but unable to defecate, melena, hematochezia, early morning spurious diarrhea. So usually when the tumor blocks the lumen, all the secretion, all the stools, all the content of the colon gets accumulated above that, and all the tumor secretions overnight will pool, and then it will liquefy the stools, and early morning there will be spurious diarrhea. So early morning spurious diarrhea is actually a feature of your left side colonic cancer, and they usually present with large intestinal obstruction, usually dynamic obstruction. In terms of investigations, number one, we have to do a colonoscopic biopsy. Colonoscopy with biopsy. You have to also perform the PET-CT, which is for staging. PET-CT is for staging. Now there is a staging that we follow, which is called as the Duke staging. In the Duke staging, we have Duke stage A, where the tumor invades mucosa and submucosa. Tumor invades mucosa and submucosa. Then there is B1, that is tumor is between submucosa and serosa. Tumor between submucosa and serosa. B2 is tumor beyond serosa. C1 is B1 with lymph node involvement. C2 is B2 with lymph node involvement. And D is your distant metastasis. D is your distant metastasis, right? So this is your Duke staging. Now how do you manage? So management is depending upon the location of the tumor per se. So we'll quickly run through that. Right. So based upon the tumor, if it is in the ascending colon, if in the ascending colon, or if it is in the cecum, then it's going to be right. This is your right side, this is your left side. So here it is going to be right radical hemicolectomy. It is a right radical hemicolectomy. Now, if the tumor is in the hepatic flexure, if the tumor is in the hepatic flexure, it is going to be extended right radical hemicolectomy. So extended right radical hemicolectomy. If it is in the transverse colon, if it is in the transverse colon, then the surgery is still the same. So you can say for both of them, that is going to be right radical hemicolectomy. If it is on the splenic flexure, then he will do left or extended left radical hemicolectomy. If it's on the descending colon, if it's a descending colon, then it's a left radical hemicolectomy. Sigmoid colon, it's a sigmoid resection. It is your sigmoid resection. If it is in the rectum, if it is the rectum, then see the lower margin is 5 centimeters from the anal virgin knot. So if the lower margin is about more than 5 centimeters from anal verge, or if the lower margin is within 5 centimeters from the anal verge, right? But Amir, we will see that. I think I've sent all the notes. We'll ask them to upload it today. I personally will also upload on the Telegram, but I'll also ask the team to upload again if they have not. Now, when you talk about the lower margin, which is more than 5 centimeters from the anal verge, then you'll go ahead with resection and anastomosis. You'll go ahead with resection and anastomosis. If it is within 5 centimeters, then you have to do an APR, that is your abdomino perineal resection. APR is an abdominoperineal resection, which is a permanent colostomy. It's going to be a permanent colostomy. Now, post-operative chemo regime that you have, we have Folfox, and then you have Folfovir. Then that F stands for, that is FOL stands for folinic acid. F stands for 5-fluorouracil. OX stands for oxaliplatin. Here same, FOL stands for folinic acid. F stands for 5-fluorouracil. IRI stands for irinotecan. So irinotecan. Okay. So these are Folfox and Folfovir. So this is how you'll manage your colorectal cancers. So we finished a 10-mark question, which is here. So to talk about two topics, that is going to be hemorrhoids as well as your fistula. Chalo. So we'll talk about the fistula and ano, and then we'll talk about the hemorrhoids. Again, short note in that. Now, fistula and ano is described as it's an abnormal communication. It is an abnormal communication. It's an abnormal communication between the anal mucosa and perianal skin. It is an abnormal communication between the anal mucosa and the perianal skin, is what we call it as the fistula in ano. This is what we call it as the fistula in ano. Sorry. Now, what are the causes, or what results in the cause? So the cause of the fistula in ano can be divided into primary and the secondary causes. We have the primary cause and we have the secondary cause. Now, single most important primary cause is incomplete or inadequate drainage of the perianal abscess or a spontaneous rupture of a perianal abscess. So it is that is either there is a spontaneous rupture. There's a spontaneous rupture of perianal abscess. There is a spontaneous rupture of perianal abscess, or there is an inadequate drainage of perianal abscess. So either a spontaneous rupture or an inadequate drainage, right? Hi Adya, good evening. Right, chalo. So in the secondary causes that you have, the secondary cause can be secondary to Crohn's disease. It can be secondary to the Crohn's disease. It can be secondary to tuberculosis. It can be secondary to radiation. So Crohn's, TB and radiation are the secondary causes. Now based upon how they are, there's a classification which is called as the Parkes classification. Parkes classification of the perianal fistula. Now according to the Parkes classification, if you quickly run through them, so this is the anal canal, the anal mucosa. This happens to be the perianal skin. There are two sphincters which are going to be present. It is the internal anal sphincter and the external anal sphincter. So let's say this happens to be your internal anal sphincter, and let's say this happens to be, your external anal sphincter. This happens to be the external anal sphincter, and let's say this is the rectum where it is going to start. So this is the rectum which is present. So here you have a muscle. That muscle is what we call it as the puborectalis. Right? So there is a muscular component which is here. So according to Parkes classification, there are different variants that you have. Type 1 variety, you see the inner, so this is your internal anal sphincter. So you'll see there's an inner opening here. It goes through the internal anal sphincter, travels between these two and opens onto the perianal skin. This is your one variety. The second variety, you will see it is piercing both the internal and the external sphincter, opening onto the perianal skin. This is your second variety. The third variety, you see the opening is in the inner half, but you see tract goes above this and then comes like this. This is what we call it as the suprasphincteric. And then one that is start from the rectal mucosa and opens across here. This is your fourth variety. So the first variety that is there, which is called as the intersphincteric variety. This is the intersphincteric type. Type 2 is the transsphincteric type. Type 3 is suprasphincteric. And type 4 is extrasphincteric. So you have intersphincteric, transsphincteric, suprasphincteric and extrasphincteric are the components of your Parkes classification. Any patient who has fistula in ano, their clinical presentation will be presence of cutaneous ulceration. There is presence of cutaneous ulceration in perianal region, in the perianal region. There will be a foul smelling discharge. There will be a foul smelling discharge. There will be fecal soiling of the undergarments. There will be fecal soiling of undergarments. And there will be history of perianal abscess. The history of perianal abscess. Now, investigation that you can do here is going to MR fistulogram. It can cause MR fistulogram. You can do an MR fistulogram. You can perform an endoanal ultrasound. Endoanal ultrasound. Management, if it is low fistula in ano, If it is a low fistula in ANO, then you can simply go ahead with fistulotomy, or you can perform fistulectomy. If it is a high fistula in ANO, then you will use a cutting sit-on. You will be using a cutting sit-on. So there are the points that you have to write with respect to fistula in ANO. It's a short mark. Okay. Then is your hemorrhoids. Now when it comes to hemorrhoids, remember hemorrhoids are classified into two varieties. You have the primary hemorrhoids and the secondary hemorrhoids. The primary hemorrhoids are those hemorrhoids which arise from 3, 7 and 11 o'clock position, and secondary one is anywhere else than that. So if you take this as a representation of the clock, this is the 12 o'clock, 6 o'clock, 3 o'clock, 9 o'clock. This is how the clock is present. If a hemorrhoid arises from 3 o'clock, if it arises from a 7 o'clock, if it arises from 11 o'clock, it is primary. If it arises anywhere else than that, if it is arising anywhere else than that, this will be called as secondary hemorrhoids, right? So hemorrhoids, if it arises from 3, 7 and 11, it is primary. Anywhere else than 3, 7 and 11 is what we call it as the secondary hemorrhoids, right? In the same context, you have the internal and the external hemorrhoids. We have the internal hemorrhoids, we have the external hemorrhoids. Now if the hemorrhoid is present above the level of dentate line, so if you draw this as the anal canal, and let's say this is the dentate line that you have. Now if the hemorrhoid is present above the dentate line, it is internal hemorrhoid. If it is present below the dentate line, it is external hemorrhoid. So above the dentate line, it is your internal hemorrhoid, and below the dentate line, this is your external hemorrhoid. Below the dentate line, it is your external hemorrhoids. Now, how would a patient develop a hemorrhoid? If you look at the overall context of it, so the causes or the risk factors that results in development of hemorrhoids, the most important and the common one is constipation. Following constipation, pregnancy. Following pregnancy, if it is history of passing hard stools. Secondary to portal hypertension and connective tissue disorder. And the connective tissue disorder. The clinical presentation of the hemorrhoids is usually bleeding per rectum. That's the only presentation that they usually have. So when you want to evaluate this in investigation, I would do proctoscopy. Now based upon the proctoscopy, we have grades of hemorrhoids. The grading is done on the basis of two things. Number one is bleeding. Number two is protrusion of the hemorrhoid. In a grade 1 hemorrhoid, the bleeding is present, there is no protrusion. In grade 2, there is presence of bleeding. The protrusion is present, but it spontaneously reduces. There is a spontaneous reduction. Grade 3, there is presence of bleeding. Grade protrusion is there, but it is manually reduced. It is manually reduced. Then it is grade 4, where bleeding is present, protrusion is also present, but here it is prolapsed. Here it is prolapsed. Management of the hemorrhoids. When it comes to grade 1, it is conservative management. Grade 2, we can do banding. Grade 3 and grade 4, we have to do surgery. Remember the surgeries that you can do. Number 1 is the Milligan-Morgan surgery, Ferguson surgery, stapler hemorrhoidopexy. So Milligan-Morgan, Ferguson, and stapler hemorrhoidopexy. In conservative line of management, it is going to be laxative. It is going to be laxative, sitz bath, high fiber diet. So laxative, sitz bath, and high fiber diet, right? So this is how you'll write a short note on your hemorrhoids, right? So this concludes your previous exam questions and how to write them, what to write, how much to write in all the topics that we have covered. That is going to be hemorrhoids as well as fistula in ano, right? So for any doubts, any questions, you can always write down to us. You have the PW's channel also. You have my own Telegram channel as well as the Instagram. It is called as the Surgery Guy. Any questions, anything, you can just get down here. It is by my name, that is Dr. Sandeep Seeram Reddy. Any questions, any queries, you can write straightly here as well. Okay. So thank you so much for joining. We'll come back with another series of Farre, discussing few more questions, and they're going to be important from the exam perspective. Thank you. Thank you. Good night.